I think the key issue for us is to take a look at the anatomy as you just described, the hill grade, to look at the transverse diameter of the crura as well as the axial length of any hernia that may be present, and to see if there's evidence of sliding. We also look, of course, at the esophagus to sort of take a look to see if there's any evidence of chronic damage. Is there esophagitis? Are there changes of chronic reflux and a change in the lining called Barrett's esophagus, which is a precursor to the development of esophageal adenocarcinoma, which is now the most common form of esophageal cancer in the United States. So we look for those sorts of issues. And then really that is sort of the major sort of endoscopic findings that we look for. I also sometimes look to see if there's food in the stomach, because that may indicate where a patient may have gastroparesis or some form of a motility disorder, which can increase their risk for reflux. So those are sort of the anatomic things we do with endoscopy. The other important component of this, of course, is to take a look at the motility or the function of the esophagus squeeze. So I try to describe to patients that when you move food down your esophagus, you chew something, you take a swallow, what happens next? You have a series of coordinated contractions and relaxations in your esophagus where one part squeezes, one part relaxes, and then you sort of propulse it down the esophagus. And in patients who have a miscoordination of that, they can have trouble swallowing. And if you now tighten up their barrier to a normal level, they may find it difficult to sort of pass food across there, and they may develop trouble swallowing, feeling that food is getting stuck, and they can get a symptom of dysphagia, okay? And so they can sometimes see that. And so that is another concern that we need to be aware of. So pre-procedure motility testing is a very key component as well of the assessment of what type of mechanical option to choose.